My name is Rose. In 2005, at the age of 60, I was diagnosed to have breast cancer. I was treated with chemotherapy and radiation therapy, and then went into remission. I met with the Hereditary Cancer program at BC Cancer and provided information of my family history. Since I cannot recollect any member of my family has cancer, I don't have sufficient information to support the screening. I was not eligible for the screening at that time. 6 years after my breast cancer treatment, I was diagnosed to have high-grade serous ovarian cancer. I was shocked to have another cancer. I received surgery and chemotherapy again, which was very difficult and challenging for me. This time, my oncologist recommended me to take a test for hereditary cancer. At that time, I had no idea I could have hereditary cancer because I was not eligible for the screening in 2006. After going through the process, the results showed that I have a BRCA1 mutation. Because I have a BRCA1 mutation, my children were also encouraged to take the blood test to see whether they have the same mutation. Those who have the mutation can get a screening from the family doctor or an oncologist. I also advise my family members and relatives outside of Canada to have the screening. Unfortunately, before I know the result of BRCA mutation, my daughter was diagnosed to have ovarian cancer at the age of 42. She was also treated with surgery and chemotherapy, but her cancer recurred 4.5 years later. Since then, she has received an oral prescription of PARP inhibitor to control the cancer, and she is fortunately doing quite well. I'm very lucky that my family took good care of me. They reacted positively to the news that I have a BRCA1 mutation and took necessary action to take care of their health. However, I know that if my daughter and I could have the access to hereditary cancer screening, the outcome might have been very different. I wonder, how has research changed hereditary cancer screening in BC? What are the current guidelines for hereditary cancer screening in BC?
When people are trying to understand about hereditary cancer, it can be a bit complicated and it can be a bit scary. And there's an easy way, I think, to make a comparison so that families can understand. And I explain it like this. If you can imagine, in your body you have 20,000 genes. And for each of those genes you have 2 copies, one from your mom and one from your dad. Each of those genes are spelled out in a code, just like a code in a book. And if you can imagine then that there can occasionally be spelling mistakes in a book, there can also occasionally be spelling mistakes in DNA or in genes. What that means most of the time is no problem, because your body can read it. Same as if you were reading a chapter in a book and you saw a spelling mistake, you'd be able to read over it and understand what the story was about. Very occasionally, though, in DNA and in books, we see that the spelling mistake might actually be in a really important word or a really important sentence. And what happens then is that the body cannot read that gene and let the gene do its function. When we talk about hereditary cancer, what that means is that most of these genes for hereditary cancer, like BRCA1 and 2, are actually cancer control genes. So you can understand then if a person is supposed to have 2 working copies of, say, BRCA1 or BRCA2 or Lynch Syndrome, they really only now have 1 working copy. And though not everybody gets cancer, you can understand then how the risks might be higher because the person really is operating with less of that cancer control gene function. So when we talk about gynecologic cancer, what that means is that we see higher rates of breast and ovarian cancer in BRCA1. We see higher rates in breast, ovarian, pancreatic, and skin cancers in BRCA2. In men, prostate cancer. There's also something called Lynch Syndrome, which is 4 or 5 different genes, but those ones are associated not only with gynec cancer like endometrial and ovarian, but also with colon cancer and other genes. So in our clinic, we're very precise when we look at patients' care. We look exactly at what their gene is, where the defect is, and how that might affect the function of the gene and what cancer risks might come with that spelling mistake. And then we can personalize a preventative plan for them.
So with respect to Rose's diagnosis in 2006, standard of care would have been to recommend genetic testing only if certain criteria were met, such as family history, specific ethnicity, or very young age at diagnosis of cancer. We also recognize that many women with BRCA mutation who were diagnosed with breast cancer were likely to be diagnosed with a very specific type of breast cancer called triple-negative breast cancer. We conducted a cost-effectiveness analysis to demonstrate that testing women with a triple-negative breast cancer was an effective means of identifying those who should undergo genetic testing. And so we had published a cost-effectiveness analysis in 2010, which demonstrated the costs and benefits of using the histotype of high-grade serous ovarian cancer in order to test women with ovarian cancer. And we did find that it was cost-effective and a better method of identifying women for genetic testing than just relying on traditional criteria such as family history, ethnicity, or personal history of cancer other than ovarian cancer. So as a result of these publications, which came out in 2010, I think many jurisdictions across the country and even around the world adopted the research results into a treatment policy and began allowing women with either high-grade serous ovarian cancer or those with a triple-negative breast cancer to undergo genetic testing, irrespective of other typical risk factors for having a mutation.
Hereditary cancer testing has historically been eligible to people with strong family histories of breast and ovarian cancer. Research has shown that we miss many families with BRCA mutations when we base testing on family history alone. We now know that certain forms of breast and ovarian cancer are more likely to be associated with the BRCA mutation, including triple-negative breast cancer and high-grade serous ovarian cancer. By testing individuals with these cancers, we can identify more mutations in the families of cancer patients and prevent them from getting a breast or ovarian cancer.
One of the things that's really exciting about hereditary cancer and research is how much it's changing. And I find this every day in my clinic where I see women that maybe I met 4 or 5 years ago, and we have so much more to offer them now than we did even then. And even within families, such as Rose's family, what we've seen is that her story would be different now. And I've many families in my practice where previous generations, women were really badly affected by breast or ovarian or other cancers. And now we have whole generations of daughters and granddaughters, nieces that have never ever had a problem. So it's becoming more and more promising as years go on. And I think also too, the interventions are going to be easier. Things like preventative surgery can be really challenging for women, but we're learning quickly how we can do those surgeries better, delay them, modify them, and implement them in a way that is easier for patients so that, a hereditary cancer diagnosis doesn't need to be as scary as it might have once been a decade ago. So it's a very promising time.
So what can you do today? If you have a breast or gynecologic cancer, ask your oncologist, is my ovarian, fallopian tube, or peritoneal cancer high-grade serous? Is my breast cancer triple negative? Is my endometrial or uterine cancer described as missing mismatch repair proteins? If your oncologist answers yes to these questions and your breast cancer was diagnosed under age 60, ask for a referral to the Hereditary Cancer Program. Ask your oncologist for a referral to the Hereditary Cancer Program if you were diagnosed with breast cancer under age 35 or you've had 2 separate breast cancers with one diagnosed under age 50. If you do not have cancer, ask your doctor for a referral to the Hereditary Cancer Program for BRCA testing if you have a family history of breast and ovarian cancer, or a first-degree relative who had a high-grade serous ovarian cancer and was never tested for a BRCA mutation. A first-degree relative is any one of your parents, siblings, or children.